I must say that was fantastic. Thank you. I think we need to stick a little bit more to time, and I'm delighted to welcome our next two witnesses, and that's Geraldine. Welcome. Thank you for coming. And Shelley Dolan, who I also work with, to declare an interest in the Royal Marsden. So welcome. And thank you for making the time out of your fairly busy schedule. And I think you probably do know us, but very quickly, if I could introduce you to the members of the panel. Councillor Teresa O'Neill on my right, and initially you will know Professor Dermot Kelleher from the Faculty of Medicine Imperial, and Nick St. who's the Member of Parliament. And you probably do know from your briefing what this is all about. I'm happy to repeat things if you want me to. But we're trying to utilise the precious time you've given us to get as much as we can out of you. So let me start first and say how fantastic it is to have you both. And nursing is one of the most important enablers in terms of leadership in London, in terms of the front line in London, and really driving change. And at the same time, nursing does have its own challenges when it comes to workforce, when it comes to recruitment, when it comes to retention, when it comes to role models like you, and really, engaging confidence in the community. So I just thought if I could give you an opportunity to tell us what thoughts you have, what could we do in this commission, considering that you're two very important leaders in London, and then maybe we'll go through some specific questions. Okay. So, your call.
So, short introduction from me.
Please.
We didn't want to talk too long,
yeah.
So our biggest challenge was deciding what to say, because
right.
We could probably talk for half an hour.
Great.
So we've tried to pick a couple of topics that are unique to London, and that are very bound up in quality of care. And by that we're talking about experience, outcomes and safety. And so the two areas really are first about staffing and how we enable staff in London, and we can talk particularly about nurses if you like, yeah. How we improve their working life. And the second area is about pathways for patients, because pathways is a word that falls off the tongue. Actually, they're not straightforward, they're very complex, and probably the only person with any accountability for the pathway is the patient, and we think that that needs to change. So I'm going to hand over to Shelley to talk about staffing first.
Thank you.
Thank you. So we think there is very good evidence that outcomes and particularly experience of care go hand in hand with the experience of staff. And one of the real issues for staffing in London, across the country, but particularly in London, is that we have evidence that we don't always engage our staff and look after our staff in the way that enables them then to have the energy to care for people through their journey, whatever disease group. So it is incredibly important, and I brought along the report from the Point of Care Foundation, which was launched at the House of Lords on Wednesday, because I think it is very much a focus that we cannot not grab now, because I think it is very, very apparent that there is an urgent need to look at the needs of staff, particularly those in London. And the Point of Care Foundation really makes the point that we've known and has been evidenced for a good while, that a precursor to good care is good care of staff. And that doesn't mean some kind of patriarchal regimen. It really means engaging staff for improvement. So we know that the NHS is the biggest employer, but it would be fantastic if we could achieve that it was the best employer, particularly in London. And we have some fantastic examples of wonderful nursing and medicine and indeed AHP care in London. But we don't always get the best from them because we're not always within organisations that utilise staff in the best way. So I think really as a kind of goal for London for the next 3 to 4 years, we need to think about how we utilise our staff in the best way, how we engage with them, how we ask them what matters and then we listen to it, and how we incentivise them. I was interested in something Stephen Dorrell just said, and certainly my view as a clinician is that one has a moral imperative every single day to think, what can I do better? But you only have the energy to do that if you think that you're going to be listened to, if you think you're important in a system. And so making sure every one of our millions of staff really know how important they are to make a difference in the patient journey.
Great.
So that's the first point.
Yep.
And I'm talking about something slightly more practical. We've got a really high turnover on the front line.
Yep.
So these are the people that are delivering most of the hands-on care to patients.
Yep.
And the turnover is high because of the cost of housing, cost of transport. And I think when you have a high turnover on the front line, the scenario that this gives you really is that the next generation of students, it's really left to the front line to train them. So we haven't got a reasonable tariff for training new nurses in London. The people that are training them are fairly junior themselves. We know in the past we've tried to do things around mortgages and around transport, but then the problem is that that's taxable. And we know this is not just for nursing, it's really about how in London can probably the mayor help to support public services, given that the cost of living is high. Within organisations, we think we need to look at the pay structure because probably the most critical person working on the front line is the ward sister role. So I have ward sisters in my organisation that are travelling out from Essex and Kent to get to work for 7:30 every morning. If you want to incentivise people to do that, either we've got to pay them or we've got to pay them enough to live more closely. So the other implication, of course, is that if you have a high junior frontline turnover, then those complex pathways, those people are less likely to understand. So we're really leaving our patients forward discharge plans, perhaps to somebody who may only have worked in the service for about 6 months to a year, and then they'll be moving on and going elsewhere. And it's a pity because most of these staff want to stay in London. It's exciting, the services are dynamic, but really their own sort of personal circumstances mean that it's easier for them to leave and continue their career outside.
Great. Thank you for that. That's fantastic. I'm just going to go and ask any questions. We're not all going to ask you questions, so we want to hear.
Can we just mention one more thing before?
Please. Yeah, quickly.
The other thing that I think would be really important to ensuring better quality care is the organisation of care.
Yeah.
So we, certainly for people with cancer and people with long-term conditions, although we have tried very hard to ensure navigation of care across many, many organisations, it's still almost like putting an elastoplast on it or a surgical suture, rather than creating a really accountable whole organisation. So one of the things that we feel would be a real bold step forward would be to think about a population and think about everybody who is accountable for care in that population. So primary care, community care, social care, mental health, acute care. And in some way construct an organisation that was truly incentivised to all work together, not as partners along a pathway, but actually all focus together. Okay. So maybe even the pay and incentivisation to be from one source for that whole organisation.
Do you think the AHSNs should be doing that? Are they doing that? Are any signs of them? thinking that way?
I think they are. So, you know, for long-term conditions, diabetes and cancer, for example, in London, I think they are, but they don't employ the various contributors to that group.
Good point. Nick, do you have any questions?
Can I just pick up this really difficult thing about housing and transport costs?
Yes.
Because in the wider London context, you've got huge pressure, which is pushing up prices.
Yes.
We know demand for housing is far, far greater than the supply, and even with increase in supply, it's unlikely to keep pace.
Absolutely.
Therefore, giving extra benefit to one particular group of people is likely probably to have very little impact, but also to fuel the inflationary process. So, in a sense, there's an argument for doing what we used to do in the past, which was to try and assist on the supply side. Now, I'm not arguing a return to building nurses' homes, but the question is whether we shouldn't be talking about measures that give advantages to people, certain key workers, and let us take nurses as one, to secure accommodation. As part of overall planning policies and housing policies and the work of the voluntary sector, social housing organisations. Is that a way forward or not?
Yes, so I'll speak and then. I think that is a way forward. I think it's probably not going to work to go back and build nurses' homes, etc. And you know that yourself. But I think any kind of scheme that would help to ensure that we keep, at least for 3 to 5 years, our young, dynamic staff nurses and sisters and you know, junior doctors in the capital, I think would be very important. And as Geraldine says, they want to stay and we want their vigour, but we can't afford often to help them to stay. So I think anything that people could help us with, we'd be very grateful for that.
I think the other angle is that we may have to accept that we have got a very mobile junior workforce. But in order then to counter that, either we need more support to train the next generation, or we need better pay for that crucial middle tier. And I think it's about the fact that health services in London are more expensive to deliver because of the constraints that we've got.
Yes.
Thank you. Yes.
Can I just come in on the back of that? You identify something that's also commonplace in social services, in that you have exactly the same sort of churn and people not necessarily having the longevity of experience. Now, in social services, it's been identified that part of the problem is the opportunity for sort of temporary agency type jobs, and so therefore people decide not to remain permanent because they get more money as a temporary worker. Is that the same? Is the same thing true of nursing? Because I mean, we hear stories about bank nurses and things like that. Is there an element of that there as well?
There is when we don't get our workforce planning right. So there's typically in nursing there's probably a 10-year boom and bust cycle. So there's a feeling that we've trained too many people, so we reduce the number of commissions. Then when that kicks in, suddenly we've got too many vacancies, we've got no more people in the pipeline, and so then we throw everything at training a lot of people in a very short time, give them a poor training experience because the people left in the organisation aren't good, or there are too many temporary workers. So I think what we've got to do is keep our nerve and not go for these peaks and troughs in recruiting people, and not think that we can save money on the front line when we haven't done anything with the service to assume you need fewer.
Yeah, that's really helpful. Thank you.
Shelley, Geraldine, can I pick you up on the very specific issue of patient experience?
Yes.
Because we know it's an intractable problem, to my mind, and we can take the example of the cancer surveys, and it places London's hospitals as being in the lower tier of patient experience. It doesn't apply just to cancer, though. It applies across the board to a range of services. And I'm sure you're quite right in saying that staff morale and the way staff treat patients is actually fundamental, but there must be more to it than this. So I'd like to hear from you specifically what you think, what measures we should be taking to improve patient experience across the board.
So 2 things stand out very clearly to me. We've done a lot of analysis on the cancer patient survey, and there are 2 things that come out very clearly, and it picks up Teresa's point just now. The first is the number of staff on the ground at night and at the weekend, so nursing staff. If you look at the number of nurses per patient on the ground in London hospitals, they are less than some other areas of the country. And that is bound to have quite an important effect, both on the nurses and on the patient. And certainly talking to the 2,000 doctors in the London Cancer Alliance, they all talk about difficulties at weekends and at night with locum and bank nurses who don't know the system, who may be very good in their own right, but just don't know the system, don't know how to get things done. So that's one issue. The other issue, I've just looked very carefully at the number of clinical nurse specialists per tumour type for cancer in London per patient compared to the rest of the country. And even at a place as well endowed as the Royal Marsden, we still have a lack of clinical nurse specialists per numbers of patients. And we know that that's statistically significantly correlated with a better experience. And I think everything that we've talked about already comes to pass here. So we need to train more clinical nurse specialists, and they need to be able to afford to live in London at a time in their career and lifetime when they may be thinking about families or other parts of their life. So they need to be able to afford to live in London, and we need to train more who want to work with our patients in London.
The language you're using focuses mostly on acute services. You're talking about nurse-to-patient ratios, and yet the previous discussion with Stephen Dorrell, we talked about the need to shift services to the community.
Yes.
And that's going to require quite a significant change in nursing workforce and practice.
Yes.
And I was at a meeting the other day, for example, where we talked about practice nurses who are a lost tribe.
Yeah.
And we see the reduction in numbers of school nurses who have a lot to do with child and adolescent mental health problems.
Yes.
So how are we going to achieve that shift in nursing practice and focus to meet the needs of the services as we perceive might be run in the future? And I think that's a real challenge, so I'm interested to know how you'd address that.
Do you want to start?
Well, I think I'd say that I still think there's a big patient experience issue around the urgent care pathway. And I know I'm going back to acute care here, but of course the solution to some of that is seen as that you push more of it into primary care. But I think the issue is pushing the right bit into primary care, where you have got staff that can deal with the needs of those particular patients. So I think school nurses, community health nurses, all these sorts of different tribes of people, we do have to try and identify the correct case mix for them. Going back to acutes again, it's the people who've been through the urgent care pathway whose patient experience is poor. So they are probably the same group of whom we're trying to push some into primary care and community care. So I think it's really getting to grips with which bit can you push successfully into primary care, and how you build a workforce to be able to deal with that.
Okay.
The other, just to build on that, it goes back to an accountable care organisation in its totality. We have community services, school nurses, practice nurses, etc. Two things. The safeguarding issues in the community, safeguarding children and adults, takes the majority of their time. And it is hugely important that we think about how we work as a total organisation, because certainly I'm on an integrated care board and I see duplication of roles between social care, between practice nursing, between primary care, school nursing, etc. And we don't have time to do it three different ways. We also don't have time for our key workers at the front line to have to navigate loads of different call-offs that the patient goes through. So it comes back to the point again, less complex pathways, doing it once, having the right person, at the right time, in the right place. Sounds like rhetoric, but actually we're wasting money and resource, and we don't have enough of it anyway. So I think the whole organisation in a geographical locality, being sure about its population needs and sharing the resource across. And it sounds easy to do, but sometimes the funding streams mitigate against it. So I think it's So looking after those staff, but also ensuring they have the same outcome goals and work together. I think we'll get there a lot quicker.
I think I'm intrigued by the concept of the accountable care organisation. I think we'll hear more about that in discussion later on. So can you imagine then that just as we're promoting generalism amongst doctors, that you might see a generalist approach emerging amongst nurses who might work more fluidly across those boundaries?
Yes, and so I'll start with one and then no. So yes and no. So one of the things that we've looked at in our community is clinical nurse specialists for long-term conditions, who would then be able to refer to the site specialist, clinical nurse specialist, in acute care. So specialists in safeguarding can work across many boundaries, and in the same way, a nurse who is confident and competent to be able to look at long-term conditions in the whole, but refer to the CNS in a hospital for particular genetic counselling around breast cancer, for example, could work quite well, I think. And there are models for that in New Zealand and in Canada. So I think internationally there are models for generalist nurses. However, I think you have to be really careful that just doesn't dilute expertise. So you have to use it in a judicious way, I guess.
I don't agree that you can have a career pathway for nurses which involves them spanning acute and community, because I think they're different jobs. So I think if you want to work in an institution like a hospital doing acute care, I don't think the same person would necessarily want to go and visit patients on a housing estate. I think it's more important that you have both types of nurses working in the same organisation, so that you avoid the handoff between organisations and the muddling of incentives.
But there is going to be an issue, though, isn't there, about increasing the number of practice nurses we have and actually increasing their exposure to different settings, because they don't get very much at the moment in primary care. So that's a challenge for the nursing workforce.
Absolutely,
isn't it?
it is, yeah.
Well, thank you for that. We're running out of time, but I had some questions. Maybe I'll be grateful if you can write to me about them, if that's possible.
Yes.
I mean, I've heard happy nurses, happy patients.
Yeah.
And which is, I couldn't agree more with. We talked about pay. The bit that you touched on was education and training.
Yeah.
I mean, King's College has a fantastic,
Yes.
and has acknowledged as a university that they should have a nursing school. Do you think the other major universities in London should be looking at the possibility of having nursing schools? Is it an issue of capacity, or is it an issue of quality of education and training? I'd love to get that information from you, even in confidence.
Yep.
Helpful to be able to think about it.
Yeah, I'm sure, and be as controversial as you like.
Okay.
The nurses per capita, if I'm correct with the announcement of the Secretary of State post-mid-staff, that should address that issue.
Absolutely, yes.
And we need to be a bit more vigilant in London about that, because it is an issue, and I agree with that, working in London. The bit that I also would like your views about is, I think we kept talking about the health delivery aspect of nursing. But, you know, the bit that I always remember as medical student is the nurse was the advocate and also was the guardian of care.
Yeah.
And the more I work with my nursing colleagues, the more that is not necessarily the case. Whether it's an empowerment issue, whether it's an issue of the system, I don't know. And, you know, what do we need to do that? And I think all sorts of politicians have tried to do that by naming nurses things, matrons and this. Names don't give you that. But what's the issues that, you know, what are the nurse leadership issues that we need to bring in? And I think that's a, and also nurses' role in prevention. You know, one of the things about this commission, you know, one of the reasons the mayor is mayor has executive powers on when it comes to health and well-being. You know, what's the role of the nurse in that? Yeah. You know, something doesn't come up, and I think it's be very important if you can give me that information. Okay. So, you know, anything else that you can think about. Okay. You know, very important role of nurses in this, and I really will appreciate some thoughts. And there's a gentleman called Jacob on the way out who will be delighted to give you his card, and we'll take that. Wonderful. Thank you again.
Thank you very much.